Imagine slipping a tiny, innocuous-looking pill right under your tongue. And within, like, 60 seconds, it completely alters the blood flow in your entire body, rushing to save your most vital organ.
Yeah, it really is a phenomenal intervention. And, what's most fascinating about that rescue mission is that the drug doesn't actually do what most people assume it does.
I mean, it's not magic, but it is one of the most remarkable pharmacological rescues medical science has ever engineered. We're unpacking exactly how that rescue works.
Right.
We're pulling from Chapter 18 of a really comprehensive medical pharmacology textbook, diving deep into anti-anginal drugs. Our mission today is to decode your heart's ultimate check engine light, a condition known as angina.
Right, and it's a critical topic.
We're going to explore why the heart protests so painfully, and then we're going to, break down the chemical toolkits used to silence that protest and keep you running. And don't worry, even though the source gets into the weeds of cellular biology, we are going to make it entirely relatable.
Absolutely. And this is incredibly relevant material to understand for everyone because atherosclerotic disease of the coronary arteries, which is the underlying cause for most of these issues, it remains the most common cause of mortality worldwide.
Wow, still the most common.
Yeah. So understanding the mechanics of how we treat these symptoms sheds so much light on just how the human body operates as an entire interconnected system.
Okay, so before we get to the organic nitrates and the beta blockers and all the toolkits, we have to actually define the crisis. Like, what is angina pectoris? Because from the outside, it looks exactly like a heart attack.
It does, yeah.
Someone experiences sudden, severe, crushing chest pain. The pain often radiates down the left arm or up into the neck and jaw.
Right. It feels very much like a heart attack to the person experiencing it. But medically, the distinction really comes down to cellular survival.
Okay, what do you mean by that?
Well, angina is fundamentally a supply and demand mismatch. The heart muscle, the myocardium, suddenly demands more oxygen than the blood flow can currently deliver. We call that state ischemia.
So if we use an engine analogy, the engine is revving hard, but the fuel lines just can't keep up.
That's exactly it.
So is it basically a heart attack that just sort of stops itself before it gets too bad?
Not quite. The defining difference is permanent damage. You see, in a heart attack or a myocardial infarction, the lack of oxygen goes on for so long that you get actual tissue necrosis.
The cells die.
Exactly, the cells actually die.
Yeah.
But in angina, these episodes are transient. They typically last anywhere from 15 seconds to maybe 15 minutes.
Oh, that's fast.
Right. So the muscle cells are absolutely screaming for oxygen, but they survive the episode.
It really is a warning system then. It's the body's way of forcing you to just stop whatever you're doing because the system is maxed out.
Yes, precisely.
But the text outlines that this maxed out state doesn't always happen for the exact same reason. There are 3 main patterns of angina.
Right. We categorize them based on the underlying mechanical failure. The first, and by far the most common, is effort-induced angina. We often call that classic or stable angina.
Stable angina. Okay, so that's the scenario most people probably picture. Someone is shoveling heavy snow in the driveway or rushing up a huge flight of stairs, and suddenly they have to clutch their chest.
Exactly.
But wait, if they have a fixed obstruction in their artery like atherosclerosis or plaque buildup, shouldn't it hurt all the time? I mean, the pipe is clogged, right?
That's a very logical question. But no, because at rest, the narrowed pipe is actually still wide enough to trickle through the baseline amount of oxygen that the heart needs to simply exist.
Oh, I see. Just to idle.
Yeah, exactly, just idling. But the moment you start exercising or even experience a sudden emotional shock, the heart's workload naturally spikes. It demands more oxygen to pump faster.
And the clogged pipe can't expand.
Right. The pipe physically cannot expand to deliver that extra oxygen, and the muscle begins to suffocate. We call it stable because the pain is entirely predictable. The patient generally knows exactly how much effort will trigger an episode.
Okay, that makes sense. You know your limits. But then the source talks about unstable angina, and it describes this as a massive medical emergency.
Yes, unstable angina occurs when that predictable pattern suddenly shifts. So the chest pains start happening with increased frequency, they last longer, they are triggered by progressively less and less effort.
That sounds terrifying.
It is. Or, most alarmingly, the patient experiences angina at rest that lasts longer than 20 minutes.
Oh, wow. So the warning light is flashing even when the car is completely parked.
Precisely. That rest pain indicates the atherosclerotic plaque is likely rupturing, and a blood clot is actively forming inside the artery right then.
So it's an active crisis.
Very active. Unstable android requires immediate hospital admission and really aggressive therapy to stop it from progressing into a full-blown, tissue-killing myocardial infarction.
Man. Okay, so we have stable, which is a clogged pipe that hurts when you push the engine. Unstable, which is a clogging pipe that is rapidly deteriorating.
Correct.
But the third type mentioned in our source, Prinz metal or variant angina, that sounds completely different.
It is a completely different mechanism. Variant angina is much less common, and the restricted blood flow isn't caused by a fixed plaque blocking the way at all.
Then what blocks it?
It happens because the walls of the coronary artery itself suddenly spasm and contract.
Wait, so the artery just violently clamps down on itself?
Yes, exactly. And because it's a spasm, these attacks happen at rest. They are completely unrelated to physical activity or heart rate or blood pressure.
So if we have a permanently clogged pipe, a rapidly clogging pipe, and a spasming pipe, we clearly need totally different tools to fix them, right?
We absolutely do.
Which brings us to the first chemical toolkit, the rapid responders, the organic nitrates. How do we actually stop a chest pain that hits right now?
Well, nitroglycerin is the prototype here, along with isosorbide dinitrate. They are the absolute drugs of choice for prompt relief of an ongoing anginal attack.
I always see this in movies. The character gasps, pulls out a tiny little pill vial, and pops one under their tongue.
Classic cinema trope.
But why under the tongue? Like, why not just swallow it with a glass of water like an aspirin?
It actually comes down to a biological hurdle called first-pass metabolism. When you swallow a pill, it gets absorbed through the gastrointestinal tract and gets routed straight to the liver.
And the liver.
Right, and your liver acts as the body's primary chemical filtration plant. And it happens to be incredibly efficient at breaking down organic nitrates. So if you swallow nitroglycerin, the liver essentially destroys the drug before it ever reaches the systemic circulation.
It's like sending your rescue team directly through a wood chipper.
A very, very effective wood chipper. But by placing the pill sublingually under the tongue, it gets absorbed directly into the bloodstream through the rich network of mucous membranes right there.
So it completely stips the liver.
Exactly. It completely bypasses that initial liver filtration. And that direct entry is why sublingual nitroglycerin works so incredibly fast, with an onset of action in just 1 to 2 minutes.
That speed is astonishing. Okay, so I want to trace the path of this rescue team. We know the coronary arteries feeding the heart aren't delivering enough blood. So the nitroglycerin absorbs under the tongue, rushes to the heart, and forces those specific coronary arteries to blow wide open, right?
Well, while it does dilate the coronary arteries to some extent, that is actually not its primary or most impactful mechanism of action.
Wait, really? But the heart arteries are the ones starving. If it's not opening them up, what is it doing?
Its major effect is actually venodilation. It dilates the large veins throughout your entire body.
The veins, like the ones carrying blood back toward the heart.
Yes, exactly. Let's trace the physics of that for a second. When you artificially widen all those large veins, blood begins to pool in them, particularly down in your extremities.
Okay, so the blood is pooling.
Right. And because the blood is pooling in your dilated veins, significantly less blood is flowing back to the heart at any given moment. We refer to this incoming volume of blood as venous return, or preload.
So less blood is actually flowing into the heart. How on earth does reducing the blood supply help a heart that is literally starving for oxygen?
Because it doesn't give the heart more oxygen. It forces the heart to do less work.
Oh.
Because less blood is returning to the chambers, the heart muscle doesn't have to stretch as much, and it doesn't have to pump nearly as hard to push that blood back out. By dramatically decreasing the physical workload, you dramatically decrease the heart's demand for oxygen.
Oh, that is wild. So it's like if someone is struggling to lift a really heavy box, instead of giving them an oxygen mask to make them stronger, the drug just removes half the weight from the box?
That captures the concept perfectly. It rebalances that supply and demand equation by lowering the demand side almost instantly.
How does it actually do that, though? Like, how does a chemical tell a vein to just widen?
So the nitroglycerin is taken up by the vascular smooth muscle cells, the cells that line the walls of your veins. Inside the cell, it converts to nitrite and then into nitric oxide.
Okay, nitric oxide.
And that nitric oxide activates an enzyme cascade that produces a molecule called cyclic GMP. You can think of cyclic GMP as a cellular messenger. It signals the muscle fibers in the vein wall to just stop gripping so tightly.
So they just relax.
Exactly. The fibers unclench, The muscle relaxes and the vein expands.
That's a profound physiological change. I mean, a drug that forcefully relaxes all the veins in your body has to have side effects.
Oh, it absolutely does. Because of that widespread vasodilation, the most common adverse effect, which happens in like 30 to 60% of patients, is a intense throbbing headache.
Because the veins in the head are opening up too.
Right, the blood vessels in the head dilate right along with the veins. It also frequently causes facial flushing and postural hypotension.
Which is what?
That's that dizzy, lightheaded feeling you get if you stand up too quickly, simply because your blood pressure has dropped so much.
Speaking of blood pressure dropping, our source material includes a massive bolded warning about combining nitrates with certain other medications, specifically PDE5 inhibitors.
Yes, this is a highly critical contraindication. PDE5 inhibitors are drugs like sildenafil, tadalafil, and vardenafil. Most people know them by their brand names, like Viagra or Cialis.
Right.
You can never, ever take them in combination with organic nitrates.
Why is that? I know they are also vasodilators, but is it just because they do the same thing and it's too much?
It's because of how they do the same thing. Remember that cellular messenger we just talked about? Cyclic GMP?
Yeah, the one that makes the veins relax.
Right. Well, nitrates work by creating more of it. But PDE5 inhibitors work by stopping the body from breaking cyclic GMP down.
Oh, wow. If you take both...
You are flooding the exact same chemical pathway from two entirely different directions simultaneously. The veins relax, and they keep relaxing, and they cannot tighten back up.
That sounds dangerous.
Extremely. The result is profound, life-threatening hypotension. The patient's blood pressure can just completely crash.
That is terrifying. Okay, so we have sublingual nitroglycerin for the immediate acute crisis, but obviously you can't live your life popping a pill under your tongue every time you want to climb a staircase.
Right.
So for chronic management, the source discusses long-acting nitrate patches.
Yes, transdermal patches or sustained-release oral capsules can provide continuous protection. But applying the drug continuously introduces a brand new complication, which is tolerance.
The body just gets used to it.
Basically, yes.
Wait.
The blood vessels become desensitized to the vasodilation surprisingly fast. If a patient wears a nitroglycerin patch 24 hours a day, within a really short time, it simply stops working. The body compensates.
So how do you manage a daily medication that literally stops working if you use it daily?
You have to build in a forced withdrawal. Doctors will prescribe a daily nitrate-free interval of about 10 to 12 hours to restore the blood vessel's sensitivity to the drug.
Okay, so when do they do that?
Typically, a patient will wear the patch all day and then just take it off before they go to sleep.
Because the physical demand on the heart is lowest while they are sleeping anyway. That's a really clever workaround.
It is.
But still, nitrates, whether rapid sublingual pills or daily patches, they're mostly about dealing with the mechanics of the veins. What if we want to change the mechanics of the heart itself? Like, how do we stop the engine from revving too high in the first place?
That brings us perfectly to our second major class of drugs, shifting our strategy to long-term preventative maintenance. Beta-adrenergic blocking agents, better known as beta blockers.
Beta blockers. Drugs like propranolol, metoprolol, and atenolol. How do they compare to the nitrates?
They take a completely different approach. Beta blockers don't focus on the blood vessels at all. They focus directly on the heart's receptors, specifically the beta-1 receptors.
Okay, beta-1 receptors.
Right. Under normal circumstances, when you experience physical exertion or emotional stress, your body releases adrenaline and noradrenaline. Those chemicals bind to the beta-1 receptors and basically scream at your heart to beat faster and squeeze harder.
And a beta blocker
physically covers those receptors. It literally blocks the adrenaline from binding. By intercepting that signal, these drugs decrease the heart rate, they decrease the force of contraction, and they lower overall cardiac output.
It sounds exactly like putting a physical governor on a golf cart engine.
Yes.
You can press the gas pedal all the way to the floor, like your brain can be dumping adrenaline because you're stressed out, but the engine is mechanically restricted from revving past a certain RPM.
That is exactly the mechanism. The heart is physically prevented from revving too high, which means it never demands more oxygen than those clogged coronary arteries can actually supply.
Which makes sense for a clogged pipe.
Absolutely.
Ew.
This effectively suppresses the activation of the heart, making beta blockers the absolute drugs of choice for treating effort-induced stable angina.
Okay, but what about variant angina? If the artery is spasming and completely cutting off the blood supply, wouldn't slowing the heart rate down still buy you some time and relieve the pain?
It seems like it should, intuitively, But beta blockers are completely ineffective for vasospastic angina. In fact, they are strongly contraindicated
Really? Why wouldn't slowing the heart help?
because it just doesn't address the mechanical failure. The spasm is a local, violent muscle clenching in the wall of the artery itself. It is completely independent of the heart's overall beat rate.
Oh, I see.
Right, so putting a governor on the heart rate doesn't force the artery wall to unclench. The artery stays pinched shut, the blood flow stays blocked, and the patient continues to experience severe angina just with a slower heart rate.
Wow. That's answering the wrong alarm.
Exactly. Yeah.
And speaking of alarms, the text is very clear that you cannot simply stop taking a beta blocker if you want to. Like, you can't just quit cold turkey.
Oh, discontinuation must be handled very, very carefully. When you block receptors for a long period, the body often responds by creating even more receptors to try and catch whatever adrenaline it can find.
So it gets super sensitive.
Extremely. If you abruptly stop the medication and remove that blockade, the heart is suddenly hit with a massive surge of adrenaline hitting all those extra highly sensitive receptors. You can trigger severe rebound angina, extreme hypertension, or even a full myocardial infarction.
Because you have to slowly unscrew the governor. You can't just rip it out of the engine.
Right, the dose must be tapered off gradually over 2 to 3 weeks.
Good to know. So if beta blockers are the go-to for stable angina, but they are completely useless for the spasms of variant angina, we obviously need a third set of tools.
We do. And this brings us to the flow controllers. Calcium channel blockers. Drugs like nifedipine, verapamil, and diltiazem.
I have to admit, when I see the word calcium, I immediately think of drinking a glass of milk for strong bones. What does calcium have to do with stopping a muscle spasm in an artery?
It's actually the fundamental trigger for muscle contraction. Inside both the cardiac muscle cells of the heart and the smooth muscle cells lining the arteries, there are tiny protein fibers.
Okay.
For a muscle to actually contract, those fibers had to slide together and clench. But they won't do that without a spark. Calcium is that spark. When calcium rushes into the cell through specialized channels, it triggers the fibers to clench.
So a calcium channel blocker.
Literally closes the door. It inhibits the entrance of calcium into the muscle cells. If the calcium can't get in, the spark never happens. The muscle fibers are physically incapable of clenching, so they are forced to relax.
Which means the artery walls relax, the vessels dilate, and blood pressure drops.
That's brilliant. Are all calcium channel blockers basically doing the exact same thing then?
They all block calcium, yes. But different drugs in this class have distinct affinities for different tissues in the body. For example, nifedipine mainly targets the arterioles, the peripheral blood vessels.
So it's working out the body, not just the heart. Right. It's a powerful vasodilator. But because it pushes so much blood out to the periphery, it can cause flushing, headaches, and peripheral edema, which is fluid swelling in the ankles and legs.
And what about the others?
Well, verapamil has a much stronger affinity for the heart itself. It significantly slows electrical conduction through the heart, decreasing heart rate and contractility. It's very effective, but you have to be really careful prescribing it with other heart-slowing drugs, like digoxin.
Makes sense.
And it commonly causes constipation because it also relaxes the smooth muscle in the gut. Finally, diltiazem sits somewhere in the middle. It has both cardiac and vascular effects, and it is particularly exceptional at relieving coronary artery spasms, making it a primary treatment for variant angina.
Looking at how these three toolkits interact, the nitrates, the beta blockers, and the calcium channel blockers, it really feels like doctors have to play a complex game of chemical chess.
That's a great way to put it.
Let me run a scenario by you that the source mentions. Let's say a patient takes sublingual nitroglycerin for chest pain. We know it violently dilates the veins, dropping blood pressure. The body senses that sudden drop in pressure and sort of panics. The brain orders the heart to beat faster to compensate.
Right. We call that reflex tachycardia. The heart rate speeds up inappropriately.
Which is exactly what you do not want to happen when a patient is already experiencing angina. You want the heart to do less work, not more.
Exactly.
So the doctor, in this chemical chess match, prescribes a beta blocker at the exact same time. The beta blocker sits on the heart receptors and says, nope, you are not allowed to speed up no matter what the brain's reflex says. The doctor is literally using one drug specifically to block the side effect of the other drug.
You're touching on the very core of pharmacological management here. Treating a complex condition like angina is rarely about handing a patient a single magic pill. It is all about layering therapies. You are constantly trying to balance the oxygen supply and demand equation while simultaneously neutralizing the side effects of your own interventions.
And that chess match gets even more complicated when you look at the patient's overall health profile, doesn't it? The text has a detailed chart on concomitant diseases, other illnesses the patient might have at the same time.
Oh, absolutely. The treatment guidelines must be highly tailored to the individual. For instance, we established that beta blockers are the first-line choice for effort-induced angina. But what if your angina patient also suffers from severe asthma or COPD?
Well, the beta blockers target the beta 1 receptors in the heart. Do they interact with the lungs too?
They do. The lungs are heavily populated with beta 2 receptors, and when stimulated, those receptors keep the airway passages wide open. If a doctor prescribes a non-selective beta blocker 1 that blocks both beta 1 and beta 2 receptors, it will successfully slow the heart, but it will also strip away the lung's ability to stay open.
Oh, wow. So you could inadvertently trigger a fatal asthma attack while just trying to treat their chest pain.
Precisely why non-selective beta blockers are completely off the table for asthmatics. In that scenario, you must pivot and use calcium channel blockers instead.
That's fascinating.
Similarly, if an angina patient has diabetes, beta blockers can dangerously mask the physiological symptoms of low blood sugar, like a racing heartbeat. So again, the doctor must adjust the strategy, often relying on calcium channel blockers and long-acting nitrates instead.
It is a highly, highly individualized puzzle. Before we wrap up our chemical toolkits, we should briefly mention the ultimate backup plan. The source highlights a relatively newer drug called ranolazine.
Yes, ranolazine represents an entirely different chemical approach. It is a sodium channel blocker. By inhibiting a specific late sodium current in the heart cells, it indirectly reduces the intracellular accumulation of calcium.
So it's sort of a roundabout way to get there.
Right. It is generally reserved as an option for chronic angina when a patient has failed all other antianginal therapies. When the standard nitrate, beta blocker, and calcium channel blocker combinations just aren't keeping the symptoms under control, ranolazine is brought in.
Got it. So let's bring this all together for you listening at home. Angina is the ultimate warning sign, a blaring check engine light signaling a critical supply and demand failure in your body.
Right.
Treating it requires a meticulous, tailored approach. Medical professionals really have to choose between nitrates, beta blockers, and calcium channel blockers based entirely on whether the pain originates from a clogged pipe, a spasming pipe, or the complex web of your other underlying health conditions. It is a brilliant balancing act.
It is a balancing act that requires a deep, deep respect for the body's internal rhythms. And regarding those rhythms, there is one final really fascinating detail from the text that I think leaves us with a compelling thought to ponder.
Oh, let's hear it.
So we discussed earlier that patients using daily nitroglycerin patches require a 10 to 12-hour nitrate-free interval to prevent the blood vessels from building tolerance.
Right.
And we noted that doctors naturally schedule this interval while the patient is sleeping because the heart is resting and oxygen demand is at its lowest.
Yeah, take the patch off at night, put a new one on in the morning. Makes perfect sense.
But consider the patient who has variant or Prinzmetal angina. Their attacks are caused by spasms, which often happen at rest. The text specifically notes that variant angina attacks naturally worsen in the early morning hours.
Wait, really? Why the early morning?
Because of circadian surges of catecholamines. Basically, your body's internal biological clock acts as an alarm, dumping a surge of adrenaline-like chemicals into your bloodstream to wake you up and prepare you for the day.
Okay.
For variant angina patients, that natural chemical surge is exactly what triggers their coronary arteries to violently spasm.
Oh, no. So if they took their nitrate patch off at night and they don't put a new one on until they actually wake up.
They are completely unprotected during the exact window when their own biological clock is actively triggering the angina attacks.
Whoa.
Therefore, for patients with variant angina, that nitrate-free interval must be forcefully shifted. They have to wear the patch overnight and through the morning surge, and instead take the patch off in the late afternoon.
That is wild. It really leaves you wondering, how many other medical treatments out there are secretly engaged in a hidden tug of war against our own body's internal biological clocks?
It is a great reminder that pharmacology isn't just about chemistry, it's about timing.
What a brilliant thought to end on. Our medications are constantly navigating the very rhythms of our biology. Thank you so much for joining us on this deep dive into the pharmacology of the heart. We really hope we've helped demystify the science behind that terrifying check engine light. Keep questioning, keep exploring, and we'll see you on the next deep dive.